Good day, and welcome to our presentation on community reentry, laying the framework for an effective prison jail reentry program. Our presenters today are Leonard Orzechowski, Reentry Director, and Reed Domer-Shank, Director of Health Information Management with Horizon Health at the Philadelphia Department of Prisons. The presenters do not have any relevant financial relationships with any commercial interests. Today's learning objectives will be to provide an understanding of medical assistance, or MA, as it relates to reentry, as well as how to effectively integrate this important element into a reentry program. We will then explore the process of establishing and managing a provider network for reentry services. Lastly, we will delve into the workflow and metrics necessary for a successful program.
Thanks, Brandon, and good afternoon, everyone. I'm Reed Domer-Shank, the Director of Health Information Management at the Philadelphia Department of Prisons. I'm really excited today to have a chance to talk about the work Horizon is doing in the area of continuity of care at release. Because if you're attending this session, it means you understand the importance of connecting patients with quality health care upon their return to the community. This is a mission both Len and I are passionate about, and so I hope our experiences can help others working toward these shared goals. To understand Horizon's work in this area, it's important to first understand our setting. The Philadelphia Department of Prisons, or the PDP, is actually a misnomer, and that it's the county jail for Philadelphia, and not actually a prison. Located in Northeast Philadelphia, the PDP is a campus of correctional facilities housing roughly 4,800 inmates on an average day. This total was as high as 10,000 as recently as a decade ago, and early in 2020, at the height of the first wave of the pandemic, due to combined efforts of local criminal justice partners, our average daily population dipped as low as 3,800. However, those who work in jails know that the average daily population is only part of the inmate caseload story. In 2019, the most recent full year of data, which is untainted by pandemic-related fluctuations, the PDP saw over 23,000 admissions to our facilities. In 2021, we expect somewhere around 20,000, and as recently as 5 years ago, that total was 35,000. This amounts to roughly 15 to 20,000 distinct patients over the course of a year, 80% from medically underserved areas. 30% are homeless. Virtually 0% come in with health insurance. All of this is to say that in Philadelphia, Horizon serves a large population of individuals. It's a population that has significant healthcare needs, which we often refer to as our illness opportunity. At any given time, roughly 40% of our inmates are enrolled in a chronic care clinic. That is, they've been diagnosed with a serious physical health condition, such as diabetes, hypertension, asthma. 8% of our population has hepatitis C. 2.5% have HIV. And of roughly 4,800 inmates at the PDP, 37% are receiving behavioral health services, and 16% have been diagnosed with a serious mental illness. Compounding these existing issues has been the opioid crisis. 1 in 5 individuals who walk through our doors are withdrawing from opioids, which translates to roughly 8% of our population being enrolled in our medication-assisted treatment program. So, you have an already very sick population, one with often a complicated set of challenges. And now, being that ours is a jail, not a prison, our task as a healthcare staff and reentry facilitator is to assess and address the needs of our patients in what is usually a very brief window of time. The chart at the bottom of the screen speaks to this challenge. While the average length of stay at the PDP traditionally hovers around 75 days, nearly half of the patients who walk through our door are released within 2 weeks. 1 in 5 are gone in a matter of days. So making a meaningful contribution here can be an uphill climb. At the PDP, there are a number of entities working toward these goals, thankfully. These include Department of Prisons social workers and reentry staff, behavioral health caseworkers, and partners from the Philadelphia Department of Health. In our presentation today, Len and I will talk about Horizon's contribution to this work, a healthcare reentry program called Release with Care. We'll talk about what has worked, what hasn't, some of the lessons we've learned over the years, and what we hope to accomplish in the years ahead. But first, a little more about Release with Care.
Thank you, Reed. Hello, I'm Len Orzakowski, the Reentry Services Director at Horizon Health. Before we get into the details of what we did and how it was accomplished, allow me to provide some perspective by walking you through a timeline of Release with Care so far. From the start, there were two main objectives: enable access to medical assistance, or MA, and secondly, set up a system to provide information and linkage to post-release continuity of care services. When considering the population metrics Reed just discussed, it was clear why these two objectives were so important. Now, before I go any further, I feel it prudent to point out one key factor. All of us in this industry understand the difference between prison and jail. The topics discussed today are from a jail setting. However, there are transferable concepts, even though there are some core structural differences in prisons. One such key difference to take into consideration is the need to see patients expeditiously in a jail setting, where in a prison setting, release dates will be known ahead of time. So with that said, the Release with Care program at PDP began as a program pilot in 2016. Since the program was being built from the ground up, the pilot involved reaching out to community providers to develop a post-release referral network, planning and special arrangements with the local Department of Human Services for the expected volume of MA applications, testing of patient engagement and scheduling methods, as well as progress tracking for the purpose of developing lessons learned and best practices moving forward. The pilot phase was most beneficial in identifying not only what worked best for us in our correctional setting, but also for identifying what was most needed by our patients. Following our successful pilot phase, which was conducted in both our male and female facilities, we moved to a full implementation of Release with Care in 2017. This initiation phase solidified the pairing of the core components of community resource linkage and medical assistance enrollment support. And during this phase, the primary focus was all sentenced inmates, which was a small fraction of our workload, but the most available for post-release planning, nearly all female inmates, as the significantly smaller population size allowed for it to be addressed by a single staff member, and male inmates with diabetes, as well as those with more serious ailments directly referred for release planning by the site medical director. In line with all of this, there was a physical expansion in the form of more reentry coordinators to keep up with demand. As we moved into 2018, the city of Philadelphia was hit with an opioid crisis, and the program focus was adjusted to mainly patients on medication-assisted treatment, or MAT, and those with diabetes. Although with this shift came workflow adjustments, reworking of scheduling parameters, as well as a need for retroactive implementation of any new parameters to ensure a fair and consistent approach to all patients that met program criteria. You could say this was the time we experienced some growing pains, though necessary and positive. 2019 was in a sense our renaissance phase, where we were able to take a step back and analyze the program from the top down and build on new ideas. This was a time of significant program growth and progression thanks to efforts focused on enhancement, streamlining, and subsequent expansion. We expanded our provider network from less than 15 locations throughout Philadelphia to nearly 50 locations across 14 separate program partnerships throughout Philadelphia and the surrounding suburbs. At the same time, we introduced a new mapping tool for community partners, improved and streamlined our chart documentation for ease of patient data collection, and as a result, we're able to expand program offerings not only to MAT patients and diabetics, but to those with any chronic condition, as well as reintroduce expanded efforts to sentenced patients. Additionally, we were also able to implement an enhanced continuity of care process for community provider notification of inmate discharges. Finally, that brings us to 2020 and the advent of COVID-19. Though the pandemic hindered our efforts as a result of shelter-in-place orders and limited movement, we were able to adjust. All medical assistance enrollment efforts continued. Linkage resources were, for the time, transitioned to directed information packets, and reentry coordinators assisted with COVID tracking and mitigation efforts. At the same time, a new role developed for the program. With the resulting expedited release orders, Release with Care became the hub for release planning and post-release information requests for community programs, the courts, the Public Defender's Office, and others, filling an ever more urgent need. Well, now that you know our history, let's jump into the meat of the topic. How you get started and why we found certain elements are necessary. When we talk about continuity of care efforts at reentry, we're referencing services such as, but not limited to, medical, behavioral health, substance use disorders, housing, and so on. Therefore, the first step is to establish partnerships with providers in the community. So why is setting up a partnership necessary? First and foremost, you will need to be able to make agreements or arrangements for inmates on their behalf. So partnerships will be needed not only so community providers know who you are in order to proceed with these planning efforts, but also to form an understanding of what you will need from them and what they will need from you to facilitate an effective system. Now, gathering community providers is dependent upon what is in your area and what population volumes you're dealing with. In our case, in a large jail setting, we focused on federally qualified health centers, established multi-facility clinics, and other widely recognized programs throughout the surrounding area. Once suitable programs were identified, the first step is to make contact with appropriate individual, generally a facility manager or regional services director, and explain what your goal is, and then set up a meeting. Initial meetings are mainly to form an understanding between two parties, recognizing constraints of the population you're planning on servicing, explaining your need to establish a community network due to varying locations of returning citizens, and obtaining provider buy-in, which is generally obtained through explanation of reentry and disease state volume metrics. Remember, at the end of the day, many of the community providers are businesses looking for more patients to have access to. Though, stating the potential community benefits of reduced recidivism never hurts. Now, before the next step, it's important to understand the differences between sentenced and pretrial. In a jail setting, most inmates are pretrial and can be released at a moment's notice. So it's important to engage them as quickly as possible, identify their needs, and provide as much information and planning as is available. Because you're most likely not aware of a release date, it is nearly impossible to make schedule arrangements with community providers. On the other hand, a sentenced individual will have a set release date, so scheduled arrangements are possible, such as pickup and transport at release for the purpose of immediate linkage to services with community providers. However, even sentenced individuals' release times may vary, and inmates could still be released early for a variety of reasons, or held longer or transferred due to cases such as detainers. These are all aspects that need to be explained to community providers, as most likely you will have to stick to referrals without scheduled appointments with the intention of establishing a file for the individual at the community provider in question. Along with this comes explaining the need for what we refer to as expedited community provider engagement agreements. Essentially, individuals reentering society are especially vulnerable to a variety of factors such as relapsing, immediate need for social support, access to health services, to continued treatment, and so on. So, expedited engagement is the expectation that whenever the time comes that an inmate is released, if they reach out or show up at a facility and a referral was sent on their behalf, they will receive immediate support and/or an expeditiously scheduled appointment so as to reduce the likelihood of complications of any of the vulnerability factors that could potentially result in death or reincarceration. We will get more into the referral process later on in this presentation, but think about the times you've called your own doctor and the first appointment they have is up to a month out. Lastly, you will want to lay out a level of understanding with community providers regarding consistency and data tracking for the purposes of outcome analysis and program efficacy evaluation. Reed will discuss this in more detail later on in the presentation, but it is important to verbalize this expectation early on. Okay, before we move into the next section, a few last items for preliminary steps include listing and/or mapping your established partnerships, as it is beneficial for use in your patient encounter process in order to easily provide information about locations, offerings, and other services. Identify which populations you want to serve, such as MAT or chronic care, and how you will go about generating appointments for them. Review of your established consent forms to ensure they cover the activities your program will be performing, such as communications with providers in the community, taking into account HIPAA laws. And lastly, identify all other necessary and applicable community resources for your patients, and develop a one-sheet for distribution as ease of understanding. As seen by the post-release support services shown here, which outlines MA support information as well as contacts for housing, food, urgent care, and other support services. So now that I mentioned MA support, let's delve into the how and why of that section. All right, so let's start this section off right away with why do we need to provide MA enrollment support? There are three main factors. Number one, I'll be blunt. Remember, as I stated previously, at the end of the day, community programs are businesses, and they need to ensure payment for services in order to keep the lights on. With that in mind, our experience has shown that nearly all of our community partnerships were very hesitant about moving forward with any linkage agreements without some assurance that health insurance or medical assistance of some form will be initiated or be in the process of being activated by the time patients were released to the community and had the potential to walk through their doors. Number two, with item one in mind, it points out the need returning citizens have for medical assistance in case they need to seek care immediately or soon after release. The idea is to limit as many barriers for them as possible so they can focus on getting back on their feet. And three, considering the higher prevalence of medical, behavioral health, and substance abuse conditions in jails and prisons than in the community, it further emphasizes the likelihood of everything stated above. Now, one thing to note before we move on. Prior to this program starting, those incarcerated at PDP with any type of medical insurance coverage represented well below 10% of the total population, and there were little to no services provided to get them enrolled before release. So, now that we covered the why, let's get to the how. What made all of this possible? There were a few key factors specifically. Agreements made with the local Department of Human Services, access to online enrollment and coverage systems, and of course, Medicaid expansion and a few key elements applicable to incarcerated persons. Okay, let me stop there. Before I go any further, it is important I make clear that what I am about to discuss are examples only. The steps, processes, and laws could vary by state or municipality. You will have to check with your local Department of Human Services office for information specific to your area. Okay, now back to the topic at hand. In our area, a small part of the legislation at the state level involving Medicaid expansion stipulated that inmates have zero income and are therefore eligible for coverage. Now, don't misunderstand. This stipulation is not mandatory to move forward. It just made the process a bit more linear for us initially and led to more workable arrangements with DHS. In addition to Medicaid expansion, our initial step in the process was reaching out to our local DHS office to facilitate multiple meetings and planning sessions. Much of it involved discussions relating to the items we reviewed with the community providers. However, once we had the appropriate channels of communication laid out, the focus was on how we were going to facilitate an effective process for both parties. What worked for us was, first off, a dedicated team to handle any questions or concerns from our program, as well as the volume of applications we were expecting. Second, considering the fact that average turnaround time for an application was 7 to 10 business days, and the fact that we would be submitting applications for an already vulnerable population that could need access to care soon after release, in working with the dedicated team, we were able to get a commitment to expedited turnaround times as long as we communicated application submissions and provided incarceration records at the time of submission. On average, application turnaround times ended up to be within 24 hours as a result of this. Lastly, was being granted access to the online application and coverage verification systems, which was essential for quick processing and submissions. It ultimately allowed us to also avoid the application process for those with coverage already. Another benefit that the legislation allowed for later into the program's life was the introduction of an inmate-specific MA application, which took into account answers to questions that would be standard for all inmates and effectively reduce the application length from 10 to 20 pages down to approximately 4. All in all, these discussions took time, but the less than 10% coverage rate quickly rose to around 50% after initiation of the process. Now keep in mind, so far, as a county institution, we have only been able to make arrangements within the state of Pennsylvania. State and county institutions may have difficulty in making arrangements across state lines, but the hope is, in the future, we will be able to expand beyond them. The chart here shows the progression of the MA aspect of the program. We hope it will help shed some light on items we have already discussed and how and why they are important together. Previously, we talked about how, prior to the program, MA enrollment was below 10%. By the end of 2018, that figure was around 50%. And as a result of the changes and evolutions to the program we are about to discuss, by the end of 2020, over 92% of those incarcerated already had coverage or had an application for coverage when they were released. Initially, we completed individual face-to-face encounters for each application and consent. This limited the applications to who we were able to make contact with prior to discharge, which was approximately 75%, and the staffing hours needed to complete these encounters. To get to where we are now, a process was instituted where we incorporated our MA questionnaire into the existing intake medical screening. This ensured everyone who walked through the door was able to participate, but also reduced staff allocation to the process and allowed for expansion into other areas. In conjunction with this move to MA data collection at intake consent forms were updated to fit the same need of capturing as many potential applicants as possible. Previously, the consent form was often incomplete or completed incorrectly. To this point, that is why we would always collect a duplicate consent form during the individual encounters. But due to its subsequent removal, we had to find a way to fix the flaws ultimately that led to decreased application volume. The updated consent form completed at intake included language that was easier to understand in a format that was easier to complete and less room for errors and omissions. As a result of reducing these flaws, we again saw an increase in application volume. Another process that showed a positive impact from being moved from early incarceration to discharge was coverage checks and applications. Previously, coverage was checked at intake and applications were submitted into the state processing system in a hold status for later processing. There were two issues here. One, often coverage would become suspended or terminated during incarceration. And two, any updates or resets to the system would purge the items in hold status. These issues led to unnecessary duplication and waste. Taking advantage of electronic daily discharge reporting allowed for a more inclusive approach. Checks for suspension status and reactivation were moved to the time of discharge, and because the MA data collection was moved to intake, the information gathered could be compiled, stored, and then reported on in conjunction with the daily discharge report, so that applications and checks for existing coverage were done at release. By submitting applications the day after release with expedited processing and a stipulation with DHS for coverage effective retroactively to the date of release, we were able to remove duplication, waste, and again, streamline the process for further resource allocation. And, as we discussed previously, the introduction of the inmate-specific MA application form from DHS also greatly increased efficiencies, as well as reduced room for error and incomplete documentation, which would otherwise reduce enrollment outcomes. All in all, I hope this provides you with a clear picture of not only how and why MA enrollment process is essential in any coordination of care reentry effort, but also how and why the items that we have reviewed make it possible and ultimately increase the positive outcomes exponentially. The last items I will discuss with you today, before I hand it back over to Reed, should bring everything we have discussed so far together, as we review identification and engagement with patients, linking them to care, and the final steps of the referral process with community providers. The first two items are short and to the point: patient selection for the scheduling of encounters and the encounter types. Regardless of the type of program you form, you will have to identify the population you want to focus on and determine how you will form a workflow to schedule and meet with them. This will vary between institutions based on need and existing processes for inmate scheduling and encounters. However, for an example, as we discussed, we chose to focus on MAT and chronic care patients. We were fortunate to have an electronic health record in place, which enabled us to use tools available within the software to identify patients that met program criteria for participation based on actions at intake and during provider encounters, and then schedule them for an encounter to meet with a reentry coordinator. Once that was in place, the encounters were delineated by a reason for which it was generated, such as MAT, chronic care, or both. That brings us to the encounters themselves and the referral process we referenced previously. To begin your patient engagement, you'll want to set up a form of script discussing the program and what is being offered. Consistency is key. This is when you determine whether the patient is interested, and if they are, move to step 2, which is selecting a community provider. By using the map discussed before, you will start with identifying the patient linkage need and where they plan on residing once they are released. The map shown here is what we use at Release with Care and is constructed using the Google My Map feature. Each point on the map includes community provider information and services available. By inputting the information just gathered, you will be able to zoom in on an area close to where the patient plans on residing and identify which locations are close by for ease of access and which are the best fit for the patient's needs. The other option mentioned is to utilize a list, which, though simple and easy to read, does not provide the same dynamic visual interface as a map. Once the selection is made, a referral form will be filled out. The referral form is a significant part of this entire process. It must include all relevant patient demographic and contact information, as well as information relevant to the reason for the referral. Also, be sure to include any information about additional services needed and a sign-off for consent to the program and the referral to continuity of care services. Remember, the intent is so that the community provider can form a file for the patient. So not only should it include basic contact information and condition information, but you should really work with your community providers to determine any and all information they would need so that it can be included in this form. Once complete, you would send off the referral to an established contact at the appropriate community provider, making sure to utilize secure channels. Now, this part of the process occurs towards the beginning of a patient's incarceration, usually within the first few days or first couple weeks of their incarceration. However, if a patient is sentenced, you of course would want to meet with them again towards the end of their stipulated incarceration period to review the information once more for accuracy, as well as to see if they would be interested in setting up scheduled services with community providers at time of release. Additionally, for all patients that referrals are generated for, you will want to set up a method of discharge notification with the community partners. Though this is more of a recent development for us, it is shown to be another crucial factor in the program as a whole. Similar to medical assistance applications being completed at discharge, a daily discharge report allows for identification of program participant discharges for which the most up-to-date medical summaries, medication lists, as well as incarceration records, or what we call face sheets, which function as a form of identification, are included. This communication not only updates pertinent patient information for the community providers' files, but also acts as an indication for them to begin outreach to the referred patients based on the contact information provided on the initial referral for increased linkage efficacy. Well, thank you. That now concludes my review of the ins and outs and the hows and whys of the Release with Care program. The items discussed should be great tools for building your own program in the future, or may help enhance an existing program focused on greater continuity of care at time of reentry. I'll now turn it over to Reed for a retrospective review before we move into the Q&A.
Thanks, Lynn. That was a great summary of the Release with Care program, and actually a nice segue into what I feel is a very important topic. With any new program or initiative, it's important to step back and evaluate not only how far you've come, but also what helped you get there. Often there are important lessons to be learned from these experiences. In our case, we were building a program with very little precedent, particularly in a jail setting. So there were valuable lessons every step of the way. I'll go over a few of those here. First, if you're lucky enough to have an electronic health record in place, by all means, leverage its capabilities as much as you possibly can. We already discussed one such example where we incorporated our MA questionnaire into the existing intake medical screening. This reduced duplicate effort and streamlined the process. It was an integration of reentry services into the EHR system that brought our MA coverage rate at discharge from 50% to 90%. The graphic below is of a light bulb coming on. Well, this was truly a light bulb moment for us. But not all steps forward have to be light bulb moments. From the start, we leveraged our EHR's capabilities in everything from automatic appointment creation based on eligibility criteria to a vast array of operational reports. Every morning, our team receives automated reports from the EHR showing all inmates discharged, which are eligible for MA submission, and the community provider that should receive the patient's data. Speaking of data, we learned early on that if you want to use data to support and drive decision making, and you should, you have to be thoughtful and intentional about how you structure your EHR documentation. We asked the system to delineate between sentenced and pre-sentenced patients when creating appointments. And that's how we discovered the majority of our sentenced patient appointments never occur because the timing of their release is so unpredictable. Understanding this allowed us to focus our efforts elsewhere. Another example, early on, we asked our team to make follow-up phone calls to discharged patients. They would actually make 3 attempts and almost never make contact, so we stopped. It was just a waste of time. But if we didn't have the data to support that decision, it would have been harder to make. Now, we're able to direct our resources to other pursuits. Finally, careful structuring of data collection is not just important for internal operations. It should be a vital consideration if you'll rely upon outside partners for information. At the risk of jumping ahead to my next slide, one of the key metrics we hope to track is show rate to community providers upon release from jail. I would urge you, when establishing these partnerships, to emphasize the importance of consistent, careful data collection. Your provider partners are likely not in the business of crunching numbers. They're in the business of delivering care. We work with over 15 partner organizations at over 50 locations. Left with the responsibility of structuring their own data collection, we would likely receive from our partners 15 or more different variations of this vital information. This was evident pretty quickly, so we developed a uniform reporting template and structure. If we were granted a do-over here, this is something we would have established, even formalized most likely, from the start. This way, not only would we be receiving the data we need, but there would be no gap in collection during the period after go live. In a perfect world, data collection and reporting would be a mandatory element of these partner relationships. Quite simply, if we can't show that our program is having an impact, there's no guarantee that it will continue to be funded. Therefore, Shared data is in everyone's best interest. So, what's next? I love this question because as much as we've accomplished with Release with Care, I know there's so much more to do. I always say we're just scratching the surface when it comes to the impact we can make, and I truly believe that. So in the months and years ahead, there are many opportunities in front of us, and I want to detail a few of those. First, we want to strengthen and expand our partnerships. This could be anything from adding partners, locations, services, to encouraging our current partners to strengthen their own contribution by coming on site for pre-release contacts, or by transportation to post-release appointments. We know that one major barrier, one major hurdle for our patients is just getting from release to these providers. So if our providers that are in place have the ability to facilitate that transportation, that could be a huge step. The PDP has initiated a system whereby inmates can be issued identification cards upon release. We know from working in this field that lack of ID can be a huge barrier for access to service. So our hope in Release with Care is to help facilitate and potentially help scale up that model with the infrastructure we already have in place. Similar to that, there's another program in the works at PDP that will help get cell phones in the hands of inmates as they're released from jail. This isn't a program we designed or administering, but there's a potential for our team to assist in identifying candidates, or even for our information, whether it be the MA information or details on the referral that we provided, to be communicated to the patients after they leave. Additionally, hopefully sometime in 2021, we look to roll out a partnership with a company in Philadelphia called Benefits Data Trust, otherwise known as BDT. BDT will be providing a customized internet-based platform where our team can guide patients through a series of questions, a process whereby when complete, a patient will become enrolled in a whole host of public benefits, assuming they're eligible. These could include anything from help with utilities and food to access to subsidized housing. Finally, in addition to adding services for our patient, we're really intent on measuring the impact of what we currently do. I alluded to this earlier in the presentation. We know the work we're doing here is important. We know from talking to patients that it's needed, but we still need data to kind of tell that whole story. Outputs like patients seen and applications submitted, while they are an accomplishment, they're not enough to accomplish this goal. Because ultimately, you can provide these services. You can put in this work, but the question is still, so what? In the months ahead, we're determined to answer the so what question. So with MA, we're going to be looking at claims paid data to measure the extent to which our patients are using their coverage. For the referral piece, it's crucial that we get that data I referred to from our community providers. And so by the end of 2021, we expect to not only be receiving monthly show rate data, those reports that I alluded to from our community provider partners, but Len is also setting up a centralized repository where all of this information can safely be transmitted and stored. We expect not only for that system to help us get the data we need, but to make it a little more user-friendly for our providers, which we know will be welcome. And last but certainly not least, with these data, we would love to begin to connect the dots with reincarceration. We know this isn't easy to do, but ultimately we want our patients to go on to lead healthy, productive lives when they return to the community, but they can't do that if they end up back in jail. So to be able to show that access to quality health care reduces recidivism, that would just be a very powerful and exciting step. .
On behalf of the Philadelphia region of Horizon Health, we thank you for attending today's presentation. The reentry program elements discussed have been critical in the development of our program, and we hope that they will prove useful to your systems as well. We will now open the floor for questions.